Assalamu alaikum and a very good afternoon to all of you. Thank you, Professor Seema and Dr. Shazia, to give me first lecture on this forum. To develop any specialty or super specialty, the foundation should be very strong. So that is why the pelvic floor anatomy, rectum, and urinary bladder is the foundation to develop urogynecology. So we are proceeding with the first lecture, that is anatomy of the genitourinary system, pelvic floor, and rectum. Now, after this session, the learners will be able to describe the anatomy of the genitourinary system, anal canal, and the rectum. And secondly, they know how to explain the functional role of these muscles to control or to have a urinary continence and fetal continence. Third, the most important part, how, if there is any, you have to identify what are the potential spaces that can lead to pelvic floor dysfunction. Any first year PG? Can you name one pelvic floor dysfunction? Any nursing staff? Just name one pelvic floor dysfunction. Okay, so this is important that after attending this session, you are able to at least know the name of one pelvic disorder. So we all know that the pelvis is made up of 4 bones, 4 joints. Go back to the UG classes. So it is formed by 2 innominate bones, 1 sacrum, 1 coccyx, and there are 4 joints, 2 sacroiliac, 1 sacrococcygeal, and pubis symphysis. And we also know what is true pelvis and false pelvis, that is divided by the pelvic inlet. So we concentrate basically on true pelvis. So when we talk about perineum, so just remember it is corresponding to the outlet, anatomical outlet, and the points are lower border. Okay, so when we go to the perineum, it is bounded anteriorly by the symphysis pubis, by the side ischial tuberosity, and posteriorly by the coccyx. So it is a rhomboid shape and divided by a line that is passing through the ischial tuberosity, and it divides the perineum into 2 triangles. Urogenital triangle is an anterior triangle and anal triangle is a posterior triangle. So what passes through the anterior triangle? As it goes with the name urogenital triangle, so it permits what? Urethral meatus in the vagina. Next is the perineal membrane. So perineal membrane, you can see it is a triangular membrane and it is bounded by the boundaries of anterior triangle. And there are 2 openings, urogenital hiatus, which permits opening of the urethral meatus in the vagina. Now coming to the superficial fascia. So superficial fascia of abdomen and the perineum. So the superficial fascia, superficial layer of the lower abdominal fascia, that is known as the camper fascia, and laterally it is connected by the fascia lata or the fascia of the thigh, and deep fascia of the abdomen is known as the scarpa fascia, and when it continues in the perineum, it is known as the Colles fascia. So when we talk about the pelvic fascia, the parietal fascia, it covers the muscle, while the visceral fascia, it covers the neurovascular system and the pelvic organs. Now there is 2 important things. What is superficial pouch or the superficial compartment, and what is deep perineal pouch or the deep perineal compartment. So whatever lies below the perineal membrane is formed by 2 layers, superficial and deep. And the space between the perineal membrane is known as the superficial compartment, while the space below the perineal membrane is known as the deep compartment. And the contents of the superficial perineal compartment is, there are 3 muscles, ischiocavernosus, bulbocavernosus, and superficial transverse perineum. Now we talk about the deep perineal compartment which lies below the perineal membrane and it is having a deep perineal muscle. Now coming to the pelvic floor. Pelvic floor also known as a pelvic floor, it is formed by pelvic diaphragm and laterally there are two muscles, piriformis and the obturator internus. So pelvic diaphragm, it is a funnel shape made up of various muscles, and the important thing is that whenever there is the direction of the pelvic floor muscles is anteriorly and medially, when they contract, they approximate the opening, that is the urogenital, and that prevents the so contraction of the pelvic diaphragm, it closes the genital hiatus and provides a horizontal levator plate on which the pelvic viscera lies. So it is one of the supportive pillar for the pelvic viscera. So levator ani, again not going into the detail because I have to justify myself I have to justify with the time also. So not going into the detail, we know that levator ani muscle is made up of three components and the most important is puborectalis. So the important part, puborectalis and the medial fibers, it forms a sling around the rectum and that helps in the continence of the feces. And it also maintains the anorectal angle which is around 90 degrees at resting face. So again, puborectalis is the intermediate part of the levator ani and ischiococcygis is the posterior part. And coccygeus or the ischiococcygis is a small triangular muscle and you can see it is situated posteriorly. Now levator plate, again there is a role in prevention of viscera and it is giving a support. It is formed by the union of the two levator ani muscles. Again, when we later on go into the surgeries for prolapse, then there is a role of this fascia and this is known as arcus tendinous levator ani and this is a thickened portion of obturator fascia. It is attached anteriorly from the pubic rami and posteriorly to the ischial spine. And there is also arcus tendinous fascia pelvis which lies anteriorly to this arcus tendinous. You can see here. Now coming to the perineal body, it lies between anal opening and the vaginal opening. It is a fibromuscular node and it is made up of, also known as the central tendon of perineum, made up of 10 pairs of 10 muscles. These are the muscles which contribute to the perineal body. Then again there are the endopelvic fascia condensation in form of various ligaments. So cardinal ligament, Mackenrod's ligament, and there are pubocervical ligament. All these ligaments, they are the supporter. Uterines, they give support to the pelvic viscera and the uterus and the vagina. And this is very important when we deal with the support, Delaney's classification of pelvic support. So there are various fascia also in the perineum and there are a lot of spaces in the perineum. So Delancey classification, it is important because nowadays when we are dealing with the surgery of the vaginal prolapse, we have to divide the vagina into three parts. If there is a weakness in the apex, if there is a weakness in the middle part, or if there is a weakness in the posterior compartment. So accordingly, you have to plan your surgery. So apical level 1 support is provided by the cardinal and the uterosacral ligament. Level 2 support is that support the mid vagina and it is provided by the arcus tendinous fascia pelvis and arcus tendinous fascia pelvis. And the last one, it is supporting the vagina and it is provided by the perineal membrane. Now, what are the functions of the pelvic floor? We all agree that it supports the abdominal perineal viscera. It provides the resistance to increase in the intra-abdominal pressure. And finally, it is also providing the urinary and the fetal continence. So these are the risk factors. Again, pelvic floor dysfunction, it is a there is a multifactorial and the picture shows these are the various Risk factors, nowadays they classify into obstetrical risk factors and the non-obstetrical risk factors. And the main thing is that if there is a weakness of the pelvic floor, it leads to the pelvic disorders in form of urinary incontinence, fetal incontinence, genitourinary prolapse, chronic pelvic pain, and sexual dysfunction. So we are discussing all these. Our international faculty is highlighting the importance of all these pelvic floor muscle and how to take care of them. Now coming to the ureter. Ureter, again it has got two parts, abdominal and the pelvic. Abdominal is from the renal pelvistic iliac vessels and pelvic is from iliac vessel till it is inserting into the bladder. So we are all aware there are important sites of ureteric injury and the cause is very important. So near this thing, it is 1.5 centimeter. It is lying 1.5 centimeter and it is crossed by the uterine artery. So it is also known as water under the bridge. This is the UG classes. Our teachers are teaching us how to, this is the mnemonic, and at the level of at the level where the uterine artery crosses, there is important site of injury also. So most common site of ureteric injuries when it is there infundubular pelvic ligament, when the ureter runs just medial and inferior to the ovarian vessel. Second is at the level of internal os, when the ureter is crossed by the uterine artery, and the ureter, and last but not the least, when it is entering into the trigon. So bladder neck, it is located at the level of internal urethral meatus. It is around 3 to 4 centimeter behind the midpoint of the sacral symphysis pubis, and bladder is freely mobile, but it is attached at the level of bladder neck by pubocervical ligament. So we talked about this bladder, and if you consider that bladder is just like this, superior surface, in base of the bladder, which is, there is 3 opening at the base, and this is the apex of the bladder, but once the bladder is distended, it becomes a spherical. Now coming to the anatomy of the rectum, it is around 15 centimeter in length, and we know that the rectum and the vagina, there is a fascia that is known as the Denonvillus fascia, which separate the rectum from the vagina, and the peritoneal relation is that upper 1/3 of the rectum is covered by peritoneum both anteriorly and posteriorly, middle third is covered by peritoneum only anteriorly, and the lower part is not covered by peritoneum. Now the anal canal, it extends from the anorectal junction, which is at the level of pelvic floor, to the anal verge, 4 centimeter. It is divided into 2 parts by a line that is known as the pectinate line or the dentate line. The portion above and the anorectal angle is formed by the puborectalis, which forms a sling, and in resting phase it is 90 degrees. Now this is very important, division is very important when we go back to the development of the anal canal. So अभी आगे मैम discuss करेंगे embryology. So embryology में ये जहाँ पे pectinate line है, there is a transition. So that is known as upper anal canal, that is above the pectinate line, and it is lined by the columnar epithelium. Below the pectinal line, the origin is endodermal. So the longitudinal muscles of the rectum, it extends into the anal canal and end up into the thin septum that penetrate into the puborectalis and external anal sphincter. And longitudinal muscles of the anal canal is also referred to as conjoint tendon. So this is the diagram. You see that the circular smooth muscles of the rectum is continuous with the circular muscles of the anal canal, and the external anal sphincter is formed by subcutaneous tissue, superficial and deep muscles. Now the sphincteric action is provided by internal anal sphincter, external anal sphincter, and puborectalis. Finally, I want to conclude that understanding the anatomy and function of the pelvic floor, genitourinary and anal canal is essential for diagnosing and managing pelvic floor dysfunction. Secondly, early identification and intervention can definitely improve the quality of life for better outcome of the women suffering from urogenital problems. Thank you. Thank you all.